So there is, thank you very much. Can you hear me?
Yes, we can hear you.
Yes, thank you. Well, on behalf of the Hellenic Society of Breast Surgeons and my co-president, Dr. John Yanas, who is a very experienced plastic surgeon who has been practicing in the UK and Greece many years, I would like to welcome you on board of our fifth webinar about innovations and technologies. As a member of the German Society of Senologic Society, the Deutsche Gesellschaft für Senologie, for many years, I was very, very much looking forward to this meeting to greet our German colleagues. I like the German Society for Deutsche Gesellschaft für Senologie very much because it is a very interdisciplinary society, including all specialties. So I think this is good for everybody. And we will have a round table consisting of innovations in breast radiology, breast imaging, minimally invasive biopsies, and breast surgery. And we have three very experienced breast surgeons from Germany, which I would like to introduce, and two very experienced radiologists, as well as two, except from Yanis, two other very experienced plastic surgeons from Athens, and one very experienced radiologist from Athens, which Yanis will introduce. We will start with the first lecture and take comments and questions after the first and the second lecture, and then I would propose we will discuss the surgical part after the fourth lecture. So I would like to welcome from the breast surgeons, Dr. Stefan Pepke, who is a chief consultant breast surgeon at the Interdisciplinary Breast Center of the Technical University of Munich, and is a gynecologist, a very experienced breast and reconstructive surgeon. Hello, Stefan. And a specialist in invasive breast biopsies, and has published about the endoscopic surgery of the axilla, and has relevant publications, and will speak about the pulse study, as we will see. And then herzlich willkommen. Then there is, I would like to introduce, no, we will not take the, lecture yet. Κύριε Ανδρεάδη, δεν το ξεκινούμε ακόμα. Απλώς τους συστήνω. And then I would like to introduce the director of the Clinic of Plastic and Reconstructive Surgery, Dr. Mario Marx, who is a general and plastic surgeon and breast surgeon with a vast experience in the breast and reconstructive surgery and autologous reconstruction, including free flaps, and an expert in intraoperative ultrasound. Dr. Caroline Nestle-Kremling, who is a commentator, a director of the Gynecology and Obstetrics Department of Gynecologic Cancer Center and Breast Center at IFEKAU Düsseldorf, experienced in gynecologic oncology and especially breast surgery, hereditary breast cancer, reconstructive breast surgery with several methods. And of course, Professor Rüdiger Schulz-Wendland, Chief Consultant Radiologist and Breast Radiologist at the University Hospitals of Erlangen, Germany. I had several courses with him, who has an extensive experience in all methods of breast imaging and fusion methods, mammography, ultrasound, MRI, and breast CT, as we will see, and has been a pioneer and published extensively, and has been a former president of the German Sonologic Society. And Dr. Carsten Rieder, who has sent us his lecture because he had a parallel duty, a radiologist and breast radiologist and director of radiology at MVZ Uhlenbrock in Dortmund, Germany, who also has received about a week ago the German Medical Award for his work concerning breast CT. And well, I will pass over to Yannis. Herzlich willkommen. To introduce the Greek colleagues.
Okay, good afternoon, everybody. As my German are not very good, I'm going to introduce the Greek contingent for this excellent webinar. And we'll have with us Dr. Mastorakos, who is an excellent, very experienced plastic surgeon, practices in Athens, and he's the director of plastic surgery department at Mystera Hospital. And he will talk to us about innovative materials and techniques in breast reconstruction. And then in our panelist, we've got another very experienced plastic surgeon for Athens, Andreas Gravanis, who is the director of plastic and reconstructive surgery clinic at Metropolitan Hospital. And also in our company, we'll have Dr. Rousakis, which is a radiologist director from Mystera and Ygea Hospital, very experienced in CT and MRI. Corina, back to you to start the talks.
Yes, we will start with the presentation, the pre-recorded of Dr. Carsten Rieder from Germany, who also received, as we see, the German Medical Award.
So, hello everybody. Thank you very much for joining my talk about the new modality of the Mama CT. I'm very happy to give you my infos about this new technique we are using here now for more than 1 year, and I thank you very much for the possibility to give you my news and my first sight exceptions of this wonderful technique. So we will start right through, and one of the main questions I heard is what it's all about. So we have some very, very nice examination methods for the breast. We have the analysis, we have inspections, palpation, and at least we have very nice technical features like mammography, contrast enhanced mammography, tomosynthesis. We are using ultrasound with duplex and elastography every day. And at least we are using a lot of MRI examinations for the breast. And the main use technique still is the mammography. It is developed in 1927 in Leipzig by a surgeon whose name was Otto Kleinschmidt, and now there are over 17 million mammos done worldwide in 2016. Now I think it's up to 20 million worldwide. Mainly it's used for screening purposes, but it's cheap, it is fast, and is highly evaluated from every point of view. But the main problem is still the pain. The pain during the mammography, which will occur through the compression of the breast, which is absolutely necessary to get a good image quality. And there are some features you can not really make better, like the premenopausal status of your patient, the premenstrual status at least 1 week for menses, the mastopathy of the breast, and the hormone treatment for elderly patients. There are some things you can change. Maybe you can learn and teach your MTRRs to make good examinations. You can change the circumstances of the examination, the atmosphere, and you can have a closer look at your mammography device and the thing how it will really is handling the breast, but at least there has to be some compression. And why? Compression leads to a reduction of motion artifacts. Tissue superimposition is a main factor for reduction of X-ray dose and scattered radiation, and also is improving the image quality in terms of contrast and detectability of abnormalities. And so it's in digital times also better for the dynamic range of the used detector. If we look at all our techniques, here's a small sum up of mammography, tomosynthesis, sonography, and MRI, and you see there are some advantages but also disadvantages. For mammography, you have no 3D imaging. You have a lot of superimposition, especially in dense breasts. You can use contrast media, you see microcogs, but the comfort most of the time isn't very well for the patients. Then you have the next level mammography, the tomosynthesis, which is a kind of 3D imaging without superimposition. You can't use contrast media yet, maybe in future, and you will see the microcogs, but the same comfort problems as mammography. Then there's ultrasound, sonography. Without superimposition, you can't use contrast media, you won't see the cogs, you have a nice comfort for the patient, and at least MRI, 3D imaging without superimposition, but contrast media is absolutely necessary for MRI. You won't see any microcogs, and the comfort, it's a tiny bore. Maybe it's getting better the last years, and also the coils are getting more comfortable for the patients, but at least it's quite annoying. So what we are missing till now is a 3D examination with a high patient comfort, which is producing superimposition-free representations of the breast, which has the visibility of microcogs and the possibility of using a contrast medium. This machine doesn't exist until now, because now we have the Mama CT, which is produced from a German vendor, and it's called AB Advanced Breast CT. You see the machine on this image, and I will come to it closer. But what are the technical aspects? What is the difference between a normal CT? So when we do a normal CT, we always are examining in an actual direction of the patient. That means there's a big detector, radiation source, which is running around the patient in an actual direction. We have a short examination time, but for every examination we do, the whole body is irradiated. We have a large distance between tube and detector, at least 70 up to 90 centimeters, and we have a resolution about approximately 0.5 millimeter. This is astonishing. This is really a great thing, at least through the last years with the iterative reconstruction. We are so fast and so sharp, crispy, isovolumetric imaging, but at least it isn't enough for the breast. This Mama CT is running another way. You see the patient is comfortably lying on a belly in prone position, and the examination is done in a frontal plane along the longitudinal axis of the breast. At least you have no radiation of the whole body, and you have a small distance between the tube and the detector. Therefore, you can come out with an extremely high resolution, down to 0.15 millimeter in an isotropic voxel. So now you have a choice to get the highest patient comfort without compression of the breast, with no narrowing tube to lie in, and with a short examination time. Let me say the whole examination with contrast medium is done in 5 minutes for both breasts. And you have a very, very high image quality in three-dimensional imaging without any superimposition. And you can use contrast media intravenously if possible. So you deliver a functional examination. You lift it from just doing anatomical images to a functional examination of the breast. On the other hand, you have a very, very low radiation exposure. It's just the same as you are doing FFDM of the breast. That's astonishing, and this is realized through this fantastic detector. So the MAMA CT now delivers something which is almost unique. You have 3D imaging, you have no superimpositions, you can use contrast media, you have microcalcs and a high patient comfort with one go, with one machine. Nothing else can beat this. And I think this is the main point of this machine. So how it works, you're looking now at least, this is the whole machine. You need not much more. It's only a table or a closet where all the computers are in. But at least you have this table where the patient is lying in prone position, and you have the opening for the breast. You have an access door on each side of the scanner. And so the patient is lying in prone position, and the breast will get into this opening board. If you open this access door, you have a look at the technique under the table, and this is a plexiglass breast cover with some numbers on it. This is the depth of the breast. So you can say the machine, okay, this breast has 8, 12, or 16 centimeters of depth. On the bottom side of the scanner, you have this chest positioning mirror. On the right side, you have the X-ray tube, and on the left side, you have the detector. And on this short video, I can show you a whole examination with opened doors, which is almost not doable in normal times, but for this video, we were able to do it. So it's a spiral breast CT technology with a short examination time. You have no scattered radiation because the patient is lying on a table. You have reduced artifacts because of the speed of the examination, and they have a very high comfort. And let me say, the longest scanning time, about 16 centimeters, is done in 12 seconds. And this is a real-time video I can show you. So you see the breast in the plexiglass, and now the scanning is started. And as soon as it starts, it goes in a spiral form downwards from the base of the breast up to the nipple. And now the scan is done in less than 12 seconds. It's extremely fast. And now you can change to the other breast and do it the same way. So these technical specifications, I don't want to go too deep in that thing, but the main focus is this fantastic detector. It's the first implication of a photon counting direct conversion detector in a technical medical machine. And this detector is fantastic. It is producing 12,000 images in 12 seconds, and it has an extremely high resolution with the highest sensitivity possible on the market, and the reconstruction indexes are working well. So in less than 12 seconds, one breast is imaged, and then you have a 3D data set of the breast. And let me say more to the detector, some technical thing. We have a single photon counting X-ray detector, and then standard CT is working like this. You have the irradiation going through the body and coming into the detector, which is made out of a scintillator, and the scintillator will give its energy to the photodiodes. They are lighting up, and the chip is realizing this lightning. And so you have an image of this quality but with the new view photon counting detector, this workup between the scintillator and the chip is spared. So it's faster, it has a higher image quality, the images are sharper, they need less dosage, and that's one of the key features of this machine. And also spectroscopy will be possible in the future. So the direct conversion of X-ray photons into image, it's a single photon counting machine with a high geometric accuracy and an extremely high efficiency. What are now my clinical experiences? These images are from my colleague in Erlangen, Professor Dr. Wenkel, and you see a CT, you have a 3D data, and you're free to choose the MPRs. You can say, I want to have an axial, coronal, sagittal, you are free to choose. Every direction is possible, and this is a small hamartoma, the corresponding sonography. Look at it, and this is done without contrast media, but it's nothing to worry about. Another case with contrast, and now you see the image in ultrasound, and you see the actual sagittal and coronal reconstructions, and you have the impression that this carcinoma really lights up, and this is I have the same impression. Every carcinoma is lighting up because of the problems with the small vessels. It's not hypervascularization, it's more an endoleak of the smallest vessels in the carcinoma and the deposition of the contrast media we are giving intravenously. So the tumor is noticeable in every direction, and it's clearly depictable. Now it comes to calcs. You see these huge tumor with microcalcs, and you see the same appearance in the native CT. This is done without contrast media for first time. You see the microcalcs. You have to realize that these images are very poor in comparison to the original images we have here with a high resolution monitors and everything. But you clearly see the microcalcs at least the same quality as you are used to it in the mammography. And if you add contrast media, you clearly see much more. This is the figure to evaluate it from a morphology to a functional imaging. You see the boundaries of the vitalizing tumor, you see the central necrosis, and you see the microcalcs in one examination. And this is the point. We have not just this, lots of information with one examination till now. And this is a case of mine. It's a patient who had breast cancer some years ago, and now the right breast lateral view is hardening, and the colleague was referring here, wondering, is there a new tumor or is there just scarring? And what the CT delivers you with contrast is a really, really nice imaging with one examination. You have the invasive carcinoma, you have the DCIS, and you have the scarring of this appearance. And you can clearly depict where are the boundaries, where are the things to look at. And I worked this case up. This is the ultrasound. You clearly see the calcs, you see the invasive and the ductal carcinoma in situ. And we also are doing power duplex. Very nice. And we do an elastography where you can realize the stiffness of this tumor. And later on, I did a biopsy. You will see the needle in the tumor, and the pathologist said we have some scarring, we have some DCIS in the middle, and we have some invasive carcinoma in the deeper parts of the specimen. So it completely was the same as the image of the CT has shown. Very impressive case, I think. One examination, 12 seconds into examination time. Next case. This was a patient which was detected in screening. So the first image you see here is suspicious. It's suspicious in an OBL view. It's suspicious in a CC view. You say there is something going on in the no man's land of the right breast and you are sure about it. If you have a better resolution, you will also notice that there's something on maybe here, but you can easily overlook that. So at least we did for assessment tomosynthesis, which is running now, and you see, oops, you see that there is the first tumor up here. This is architectural distortion, and there are two more tumors showing up medially. So first 1, 2, 3 tumor localizations. I will run it again. Tomosynthesis, very nice technique. Kind of 3D. Then we did a workup. It's the ultrasound. Yeah, you see the measurements, you see the biopsy, you see the power duplex, and at least the elastography of this stiffened tumor, very typically. And then we did an MRI, and what you notice maybe are these lesions. It is showing up here, here, and here. It's very fast, at least. I will stop next time. Also in coronal reconstructions, you can see the appearance, but if you really doesn't notice what's going on, and you have to compare ultrasound, mammography, tomosynthesis, and MRI to be sure and to realize where are these different lesions in this breast, in this multifocal carcinoma. And what I show you now is a simple 3D VRT reconstruction of this patient in a mamma CT. This isn't the plain MPR I showed you before. This is a 3D reconstruction which is done automatically with the modern software we are running. And this won't take you a second. It's done automatically, and you can see clearly the tumor localizations in the breast. 1, 2, 3, and even one more. There's a small lymph node in the mamma here. It's more laterally than the 3 tumor localizations, and yeah, all this was also seen by the pathologist. So normal breast. Now there are pain-free examination of implants, because the examination of implants is tricky, I think. You can examine those patients easily with a mamma CT. So you're going on without any breast compression. You have no risk of rupture of older implants. This may occur in your practice once a year, twice a year. It's horrible. High resolution 3D images of the breast tissue, the implants, and the surroundings, like the muscles and everything. You see really everything of this breast and the implants. And you have in one go a unique display of calcifications, at least for the fibrosis of the capsule. So a very unique, very helpful technique. This is a young patient which showed up in my praxis with a palpable lesion on the middle of the left breast. And she was running around Germany and getting ultrasound, getting mammo, but nobody told her what's going on, and she was nearly before taking those implants out, and we did a mama CT, and what you see here is very nice. With some simple dragging the mouse, you can cut away the tissue, you can have a deeper look into the breast, and you see on the implant, and you see that there's a infold of the implant, which was annoying her. It's simply an infold of this implant, nothing more. No tumor, no rupture, no reason to reoperate or reimplant anything. And she was absolutely happy. With one examination, you have also the opportunity to have a look at the glandular tissue. Perfect. 12 seconds examination time. This is done without contrast media. And again, back to the cutis. So one thing I pioneered here in Dortmund was the high resolution 3D CT galactography. This is at least 3 up to 6 times a month that a patient occurs with a bleeding mamilla, and we are still doing our galactographies, and I figured out to do this technique and transfer it into the CT technique. So we did first time 3D imaging of ductal structures in high resolution without any breast compression. So the natural form of the breast is still there, and you can also use intravenous contrast to get an enhancement of papillomas or ductal structures and the surrounding tissues. And this is a patient with a permanent secretion of the right breast, and we did a normal galactography where you see a big intratubular structure here in the right breast. And what we did further was a CT. After giving the contrast, we did a CT, and this is what comes out. You see the VRT of this galactography, and as soon as the tissue is removed, you see the ductal structures. For the operating person, for the surgeon which is going to have an operation on this breast, it's absolutely fantastic to get an exact idea of the localization of the papillomas and the ductal structures. It's very helpful for a pre-operative imaging. Yeah, you can go through the ductal structures. At least I have to get more the contrast media a little bit thinner in future, but it's I think it will be a reference for intraductal structures in the future. Also on this image or video, you can see it's another VRT I did from this case, and you see the corresponding galactography, and it's absolutely astonishing what we can realize with this resolution. This is 0.15 millimeter in every direction, and again back in the VRT. So astonishing image quality with absolutely reference, especially for this examination, I think. So the limitations of this machine, you have to know in practice. These are patients with massive HWS problems. If you can't move your head, you can't be examined. You have to lay prone, you have to turn your head to the side. HWS syndrome is also a problem. So, but besides that, nearly every patient can be examined without macromasty. So breasts bigger than cup E it's not possible to get it into this small cylinder, and the weight can't be more than 130 kilos because the structure of the whole machine won't take much higher loads. Conclusions. With the Mama CT, we are now having an examination modality which delivers you 3D images of the breast without superimposition. There's functional imaging by using contrast media. You have high resolution 3D images in an isotropic technique. You have an excellent contrast between the glandular tissue and calcifications and tumor if you use it with contrast. You have a very short examination time, again, 5 minutes, complete examination with contrast. You have a very low dosage, same as an FFDM, and outstanding patient comfort. And the indications for the Mama CT, I see it's at least for all the patients who have a very painful mammography and the fear of pain, maybe personal reasons not to get touched at the breast, who are in need for further clarification of conspicuous findings like microcalcs. We can use contrast media to get a grip on the multicentricity of a tumor or the exact tumor size. With this technique, we can plan the surgery, the giving the gynecologist surgeons a clear idea of how the tumors are localized and how big they are and where they have to cut the breast. It's absolutely great for monitoring during neoadjuvant chemotherapy. It is very helpful for patients with a contraindication for MRI, for example, pacemaker, claustrophobia, implants, cochlear implants, contrast media allergy. It's very, very helpful for patients with silicone implants because you don't have to do a compression, and maybe it's a reference for those patients in future. And it's also maybe a reference for patients with a secretion in terms of the 3D CT galactography I showed you before. What are the costs? In Germany, at least, it's a private idea. You have to pay it privately. If you have a private insurance, this will give you back the money, but for stationary health insurance person, it is not possible to get a reimbursement. The cost for a private examination complete are about 350 euros, and we are scheduling routinely over our direct office. So thank you very much for your attention, and I hope you have a good time and enjoyed my talk. And yeah, just write me emails, look at my LinkedIn profile. There are some nice cases, and I think this technique will have a very, very great future, and I'm very happy that you joined my talk. Thank you very much again, and bye-bye.
So we would like to thank very much Dr. Carsten Rieder and congratulate him again for winning the German Medical Award. He told us that he can take questions. We can send them to him if we have some more questions than will be discussed in the panel. We have two excellent radiologists in the panel, except for Professor Schulz-Wendland, whom I introduced. It is the colleague Dr. Arkadios Rousakis, who is a director of CT and MRI department at the big private hospitals Semidera and Ihia. So I asked Professor Schulz-Wendland, as he has this vast experience with all methods, to give us some comment about the different methods and their role, and especially the role of CT.
You hear? Is this okay with the contact? You hear me?
Yes. Yes.
Okay. First, I want to say what Dr. Ritter is talking is very nice and is interesting, but I don't like it when it's not talking of the basics of some systems. First, I want to say that's the development of the CT breast made by Professor Kalender in shortly cooperation with the University of Erlangen. That's the first point. And when you say he has the system of CT breast a long time, that is very interesting, but we have the first system in the whole world is in Erlangen. And that's very important to say because there exists at this time an update of this CT breast, and we have nearly 5 years when we control this and have our studies. You can read it in European Radiology next journal next week, and that is a scientific thing. I think it's important to say this first because I don't like it when they are speaking like a merchandise. Therefore, this is the first sentences. Talking about CT breast, we use this CT breast, and I want to say the following thing. The interesting point is that we have a new system, but we have to ask, the question is, for what? For what have we the system? For example, when we do CT galactography, we can do MRI galactography, no difference. No. The question is, in MRI, we have brilliant images, but we don't see microcalcification. In CT breast, it is possible to see microcalcification, and that is the important fact. For primary diagnosis, it's not necessary because we have a small department, Alan. We have only 20,000 patients per mammogram every year. That's not very large, of course. But when you use CT, there you have to know at every breast you have 4 to 5 milligray. We have published this, and with Professor Kalender, of course. And when you use digital mammography, for every breast, 2 milligray maximum, first point. Second point, you use contrast media, and that is a difference when you have an MRI and contrast media with gadolinium. In this case, you use another kind of contrast media. You use this when you do an angiography or so on. Therefore, when you have the problems to discuss with a patient, you use much more time. And next point, you have only for one breast for the examination. And in this time, it is difficult to say the flow of the contrast media, how many images, etc. There are some problems, but therefore, with Professor Kuhn from Aachen, we have a large study now, and we think it is a nice equipment, very interesting equipment, but it is for assessment, First, we have clinical examination, mammogram, ultrasound, elastography, what you want to do. That's not the problem. But then it's the question, multicentricity, the largeness of the DCS, that's important for Mario Max, for example, or for Stephen Petke, for example. How large? And then it's a possibility with a CT breast to have a real 3D image of the lesion or the microcalcification to talk about the largeness and to take for microcalcification to make a classification of the microcalcification. That is the point we discuss, and we have that is where Dr. Ritter is talking. That's from Uhlenbrock. I know this every time, of course, but there's a new system, an update of the system. We have this, of course, and I think that is the problem because we work now in the question when we see lesions and microcalcification to do the interventional method. The future will be CT breast interventional method using. And that is what we have at MRI. We have this. We have for tomosynthesis interventional method, stereotactical, of course. That is what we are working to. And what Professor Kuhl says, the problem is they have the directly study, clinical examination, or what you do, MRI and CT. And then we won't see it and compare this with the pathology to look to the results. That, in my point, and I'm coming to the finishing, is the point, it is nice to have for assessment. And that is what we are scientific working. Thank you.
Thank you very much, Professor. Thank you. Dr. Arkadios Rousakis. Arkadios, would you like to give a comment?
Good day. Thank you for giving me the opportunity to comment on this interesting lecture. Without any doubt, photon counting CT, which is the technology beyond the method that Dr. Rieder described to us, represents an exciting new technological achievement in imaging. It is postulated that photon counting CT, it probably represents the most important technological achievement in imaging during the last 10-15 years. However, it's now the era of beginning to be commercially and clinically available. Regarding the specific application of photon counting CT in breast, I would like to say that there are still very few clinical in vivo data and very few studies to support its wider use. I totally agree with the comments that were previously expressed by Professor Schultz-Wetland. Probably there are many issues that have to be addressed before we talk about a wider use of the method that Dr. Rieder described. For example, we have to be more sure about the radiation dose, especially in dynamic contrast enhanced studies that were described as a possible application by Dr. Rieder in order to replace MRI. Even if the counted dose is low and, as it was said, comparable to mammography, how it will be multiplied if we do repetitive scans to have a dynamic study similar to that of MRI. Also, we have to do direct comparison studies with digital mammography to evaluate the real efficacy of photon counting breast CT for evaluating thin pleomorphic calcifications. Okay, technically it has a very high spatial resolution, but if you intend to thoroughly examine the morphology of very thin pleomorphic calcification, it has to be proved that it can beat or be compared to digital mammography or tomosynthesis. Finally, cost and availability of the method are a major issue. Up to my knowledge, nowadays, a system for photon counting breast CT costs more than €500,000. Of course, we expect the technology to be cheaper in the next years, but this is a very high cost. To my opinion, I believe that a possible future indication for using photon counting breast CT could be in cases of suspicious microcalcifications in order to evaluate possible neoangiogenesis in direct correlation to the site of microcalcifications. An issue that sometimes is not easily done with MRI, given the different positioning between MRI and digital mammography or tomosynthesis. This could be a possible indication. Also, in cases we have problem to perform MRI, like severe claustrophobia or other contraindications, I don't find a possible indication for implant evaluation, or for example. These are my comments, and thank you for giving me this opportunity.
So thank you very much, Dr. Rusaki. Are there any other comments or questions?
I want to say to the colleague Arkadios, that's right, Arkadios, yes?
Arkadios, yeah.
Excuse me, I'm so often in Greece like others, but it is difficult to speak this. Okay, what you say, I understand this exactly. A multi-slice is very interesting. Photo counting is interesting, but we have to look for this very, very expensive equipment to look where are the indications. And I say at this time, it's interesting to make the comparison of MRI and CT in the question of assessment when you have something found. And the small question with the contrast media, that is not the small questions. When you have gadolinium, you never have reactions. But with the others, you know this from angiography and like this, you have to talk a much more time with the patient and you have much more reactions. That's all our questions we have to find out. Interesting, of course, and I like it. And we have studies European radiology next month, for example, not to lead, only to read, to have the brain for this. And what you say about contrast media, mammogram, that's very important too. I say to you, I like much more to have an MRI. I said, okay, when you don't have an MRI, I think that is assessment. Contrast media, mammogram, helps you in the question where you want to see the largeness exactly, more exactly than with mammogram for assessment. I think at this time we have the question for assessment when you have detected something in mammogram and ultrasound. That is, I think, the point of all.
I completely agree with you.
Thank you. Thank you very much for this comment. Thank you both. I would like to proceed to Dr. Stefan Pepke, who will speak to us about the PULSE study, the neonavial axilla biopsy system. Dr. Pepke.
Okay, hello, dear colleagues. What I want to go for is to present more or less a new opportunity from the technical side to go for biopsy in breast and axilla, and it is more or less the bridge from the session from the morning. The lecture from Professor Mokbel from UK, he was pointing out that it's rather difficult to do biopsy and to place seeds into an involved lymph node if the lymph node is very small, or if the metastasis in the lymph node is very small, with all the difficulties around target axillary dissection, what we have heard in the lecture, and what Andreas from Sweden was talking about, that is very necessary to ask surgeons, radiologists, doctors, if the industry is developing new devices. Is there a need? Is there an unmet medical need? And what we are talking about today is the end point of a 10 years story to development a new biopsy device. Everybody here in this forum is knowing that we have brilliant devices for different kind of biopsies, and Neodynamics from Sweden came up with a new idea for a PULSE system. The background is, what we know is that getting biopsy material from the first moment of breast diagnosis is very important to decide and to trigger the decision for treatments for neoadjuvant chemotherapy. What we did is to test if redundant biopsy is relevant for covering the whole treatment process. In neoadjuvant hormonal therapy, we did redundant biopsies for proving the Ki67 in case of luminal A, luminal B tumors. So there's a lot of need for specific and very precise biopsy methods. And what we have seen in this development of these devices, what is necessary to combine the normal core needle biopsy for easy biopsies, the vacuum biopsy system for removing in a therapeutic or diagnostic way unclear lesions, BI-RADS 4, BI-RADS 4 ABC. So all these things coming together with a mechanism, and from the clinical standpoint, it was for us really relevant to do redundant biopsies. Here is a patient years ago from the Gepa protocol, in which we did redundant biopsies in the breast tumor. You see the tumor that was biopsied 6 weeks ago. Then I set a clip, and then we tested if after a couple of weeks after treatment, the tumor biology is changing. And so you have to have really an exact sample of the field of the region of interest. And regarding the technical issues, this new flexible pulse system is a different way to move the needle forward. What we have with the BART system or with the typical core needle biopsy system is that with a high-speed mechanism, the needle comes into the tumor, into the lymph node, and there is a risk for destroying tissue and the behavior of the lesion or on the behavior of the axilla. And the pulse system is in a very slow motion with a good guidance sonographically to go in front of the tumor with small pulses, with a very controlled mechanism to go through the lesion and to remove the sample in different ways. And the normal core needle biopsy, as we need, with a vacuum biopsy, the basic system is absolutely the same. So the focus of the first trial, because we as clinicians said, okay, it is very easy to get biopsy material from breast tumor. So we are experienced enough to go for biopsies also in small lesions. But what is very difficult and complex regarding the anatomy, regarding the vessels in the surrounding, that is the axilla. And the main focus for us as breast surgeons is how to deal with the axilla. First of all, we have to have really good tissue for having a diagnosis. If you are asked a pathologist, the pathologist is saying, okay, remove the lymph node and then you will have the diagnosis. But it's a contradiction of our approach. We want to go for minimal invasive techniques. We want to have the diagnosis. Is it the pathology reported lymph node metastasis or not? And the most difficult thing out of my perspective is the metastatic process in lymph nodes is starting in the cortex. So if you have small lesions in the cortex, it is very difficult to aim and target it really the cortex. It's not necessary to have material from the lymph node per se. You have to have these biopsy from the region of interest. So these are lesions between 1, 2, 3, 4 millimeters. This is very easy with a normal biopsy, with a normal core needle biopsy to have material from a big lymph node metastasis, but it's not the aim. The aim in the focus of target axillary dissection and neoadjuvant chemotherapy is to have a precise diagnosis also from smaller lymph node metastasis, and not only from one lymph node, sometimes from 2 or 3 lymph nodes. So we characterized really a subset of what we called difficult or high-risk biopsies, and that was placed in the axilla. The principal investigator of this trial was Mark Till from Frankfurt, and we had a panel of trialists. They are focused on this pulse trial. The inclusion criteria, independent on the multifocality, multicentricity, was a lymph node, what we're saying it is suspicious. And that is the first moment what's triggering the whole process of diagnostic and treatment of a patient. So because in Germany, you know, the majority of patients who need chemotherapy will have the chemotherapy first as a first step as in a neoadjuvant setting. There's the triple negatives, there are the HER2 positives, and the luminal B tumors. So what we did and we tested is the NeoNavia biopsy system with a high efficacy for having good material, for good detection of lymph node metastasis. And what you are seeing here, that is a lymph node that is moderate suspicious. The cortex of the lymph node is a little bit bigger, it's a little bit unharmonic, it's a little bit unbalanced. So that is in the middle. Is it suspicious? Is it not suspicious? It depends. Is it after the breast biopsy, or is it the moment as you see the patient at first? So the aim of the game is to set and place the needle exactly in the cortex of 3.5 millimeter, and to have some biopsy material for proving not only the dignity, also the tumor biology of the heterogeneity between the tumor and the lymph node is occurring. And the visuality, what you have seen here is, and we see, okay, the needle was in the cortex of the lymph nodes. Regarding the risk parameters, what we characterize, what is a suspicious lymph node, what is a difficult lymph node to biopsy, the proximity to vessels smaller than 5 millimeters, proximity to the muscle smaller than 5 millimeters, proximity to the thoracic wall smaller than 5 millimeters, and the lymph node has to have smaller than 10 millimeters. And in hope that the whole panel is agreed that this is really a tricky procedure. I don't know if everybody is able to focus, okay, in these risk parameters to say, okay, I'm completely safe and stay with a good mood for the lymph node biopsy. And then we characterize minor risk parameters, and they has to have the panel of minor risk parameters to say, okay, that is a complex lymph node biopsy that is listed here. So the BMI over 30, the BMI below 18.5, that means in very tiny patients, the skin distance below 5 millimeters. So all these things what make the biopsy more complex. The primary endpoint was the rate of successful biopsies, so defined as success rate, and the secondary endpoints, of course, all the rate of adverse events, rate of patients presenting with what kind of risk parameters to say, okay, that is more or less the frame of risk parameters, what makes these things difficult, and all the quality parameters around a normal quality assessment of a biopsy. The mean age was nearly 60, in a range from 26 to 84. The mean lymph node size was 17.7, range from 7 to 46 millimeters. And the success rate for tissue sampling from the lymph node was 93%. So nearly, in a near of 10% with failure, and that is absolutely acceptable. Regarding adverse events, hematoma visible via ultrasound in the axilla occurred in 1.7%, 2 of 115, 1 mild, 1 moderate, didn't requiring any surgical treatment. So with compression, the problem was solved. And the pain in the axilla measuring by a visual pain scale was reported only in 2.6%. That means 3 of 115 patients, 2 mild, 1 moderate. No requiring of any kind of additional treatment. It's clear we set the local anesthesia for the biopsy. What we characterized in 95% of the patients, they presented with at least one major or one minor risk parameter regarding the anatomical complexity of the axilla. In 43%, the patients presented with at least one of 4 major risk parameters in different ways: distance to the vessel, distance to the thoracic wall, distance to the skin. And what we obtained was an average of 2.68 samples per patient with a mean of 1.36 needle insertions. That reflects, or vice versa, there's a little bit of uncertainty how much tissue we have to remove from the lymph node that the diagnostic is sufficient. What we have in our guidelines in Germany is for the breast tumors, for the breast lesions, for characterization of the dignity is 3. The recommendation is around 3 biopsy samples, but it's not really defined for lymph node biopsy. At the end, it is not necessary to have 3 or 4 or 5 samples. What you have to have is 1 sample with good quality of tissue. So the asking the characterization of safety, the pulses facilitate the control during the needle insertion of around 90%. And the pulses facilitate the stabilization of the target lesion during the needle insertion, also in a range of 90%. So at the end, what we have to say, the procedure was in our hand absolutely feasible. And that can to be translated into clinical routine. The device is on the market, so we are able to implement it if there's a need for our daily routine in the breast center. And once again, we have the opportunity to implement all these kind of needle sets to place for the right lesion, the right kind of needle. So the summary and the conclusions from the PULSE study was the biopsy device was safe. It was very effective in taking biopsy material in the axillary lymph nodes. In the patient cohort with really a subset of risk factors, the mechanism of placing the needle in the lesion to getting the material, the pulses were perceived to stabilize the target lesion and enhance the needle control during the insertion. And it was possible, that's clear and reflects the efficacy, it was possible to obtain multiple samples with a single insertion. And so with this background, the new needle system was created. So on the market now there is the newest version. So we reduced waste, we focused on a needle shape, we focused on the mechanism, and at the end of the game, once again, 10 years of development, 10 years from the first idea to create or to have this pulse mechanism to this kind of device. The setup was more user-friendly, no cables, no vacuum canister. What I've said, the medical waste, it is a single-use needle, is minimized to really what's really the need for that. So we reduced it with 85%. The base unit noise level, and it was one of the most important point. What I was disturbing from the first version, we minimized it to with 70%. The weight was reduced. There's a 4-wheel motor for better mobility. It is a single-hand operation. What you are seeing here is this different kind of needle. In the middle, the normal, I would say the standard needle as what we have is the core pulse needle. Then we have a flexi pulse needle with a little bit more, or 25%, 30% more gain of biopsy material for more complicated lesions. And then we have the 10G vacuum pulse. The mechanism is what I mentioned before. The mechanism is nearly in the same as we know the efficacy from the vacuum systems too. The clinical data leading to CE market. So then there was a benchmark comparison to the standard devices on the market. So you see the comparators was tested, especially in the vacuum biopsy. It was very necessary for us to see, okay, what is with the standard technique with the mammotome elite, and we know these mammotome techniques over, I would say, nearly 20 years. And what we have seen is that the needle performance was gaining biopsy materials in different models of, these are models, not in human, these are models from different models of tissue, so that they're gaining biopsy material in comparison was slightly and significant better in comparison to the material what is as standard on a market. So my very point of focus was that we have to have in our hands one system for all ultrasound guided breast biopsy procedures, and that is without any focus on marketing. That's what we can implement it now in daily practice. And so I say a very warm thank you to our colleagues from Greece, and I'm very happy we did at the end of 2019 the last surgical workshop with colleagues from Greece, and it was really in a good and warm moves, and hopefully we have the chance to come together in the latest in the next year. Once again, thank you also to Cornelia to organize all these things in a very perfect way. I hope we will have a vital discussion. Thanks a lot.
Thank you very much, Dr. Pepke, Stefan. The Klinikum Rechts der ESA was the first hospital where I stepped my foot in as the first year student at the LMU. So I have very good things to remember. Are there any comments? Would Dr. Caroline Nestle-Kremling want to give us a comment about this biopsy system?
Yes, thank you for introduction, and thank you, Stefan, for this wonderful talk. I haven't the opportunity to use this device, and I think all the advantages you showed us very well, so that I would like to use it. But maybe some questions, just to get an idea. The cost for the machine, for the device and the needles is within the range of what we know from vacuum biopsies?
No, that is, it differs. The basic machine is, that's of course more expensive than every single biopsy device what you're using, but the combination and in comparison, I'm absolutely not in pricing and how Neodynamics will develop the price for the WHO scenario. But what we have a focus is that it has to be not more expensive as the usual single devices what is on the market. So we started years ago with the mammotome. That was a question of pricing. Our colleagues in Tübingen, Ute Kreinig-Strobel, Ines Gruber, and Markus Hahn, they analyzed a lot the issue of the cost. And in Germany, all the kind of vacuum biopsy is not, sonographic guided vacuum biopsy is not in a correct way reimbursed, and that is a problem. I would say if you go only for vacuum biopsies in normal lesions, you will fail regarding economic aspects. But if you take into account the whole set of needles, with the efficacy in I would say in the more difficult biopsies, you are in the price frame what is usual for Germany. Caroline, the only chance for a company for placing their devices in the German market system is to stay in our framework of economics. And so perhaps in the US, you can go for, I don't know what. I was so astonished as we have heard what the radiologists from the US will get for simple biopsy. So that is absolutely not possible in Germany. And so we have to place this in in a normal range of what we get for. So because we have our controller in our clinic, so we have our own controller, and he is, trust me, he is focusing on spend not more money than is absolutely possible into the system, and he make his hook under this certification, say, okay, in this frame it is possible if you go for a lot of biopsies, what we do in Munich.
Yes, thank you. It was just to get an idea. Maybe the question of the clipping, using the clips, is there a combination? Can you use specialized clips for this device, or do you use...
if you go for coaxial needle, you can go for what we did with every kind of clip what you are using in a normal range in your daily routine. And what I have heard from Neodynamics, they try to avoid every problems with every clip what we are using in daily routine, and they are in the process of creating a clip for using in this kind of device. But otherwise, via coaxial needle, you can go with Somatex or with a seed or what you are going for in your clinical routine.
Okay, thank you. So one of the main advantages, therefore, you presented the study like in the axilla, is putting less damage to the surrounding tissue as vessels, etc. Did you compare it to former like two-cut biopsies?
Yeah, it was not a randomized trial. It was really, and that was the idea of Marcus and me, so that we are focusing really on the most difficult subset what we define, not these usual things we compare to biopsy. So the detection is 93.5 and 94.2 with any statistical significant, because everybody who is a little bit more advanced is able to do breast biopsy with whatever you want. So we focus on the subset of the most difficult patients, and the next step is to go into clinical routine not in a randomized way, but to place the neonavia biopsy in all the armamentarium what you are doing, and then to have a registry. The idea came also, of course, from Thorsten Kühn and Mark Till, with the background of the Axana registry, that we do exactly the same thing. We go for registering all the biopsies, what we are doing, and at the end, you will have the efficacy data. I know that is biased because it is not a randomized trial, but it is not biased because it is placed in the routine across Europe. Everybody who want to join in, that is a small piece of, or it's the Excel sheet, we can do it online. It's clear to say, okay, that is my lesion characterization. That was the time, that was the blood loss, that was the pain scale, and all these things. And then we have, I think, a whole picture from clinical routine.
Yeah, thank you so much. I think this is one of the points we can discuss also the first presentation with this point of register studies. Maybe Rüdiger Schulz-Wendland, yes, you would agree to do register studies for these rare cases of the breast CT use, yeah?
But I want to say to Stefan, I know the system, and I think it's very, and it's very interesting, the system. But I think the axilla is a problem in this time, every time. At this time, we use another way. We make a core needle biopsy, and in this way, we are doing a clip of a localizer called from Hologic. We can talk about manufacturers. We have no problem, because you can find this very well, because Markus Hahn has written that 30% of the clips will not found when you make an operation of the axilla. Mario will say something about this perhaps. Therefore, the system of you is okay. This is okay, yeah. But I think we have to think. We make core needle biopsy and localizer. Yeah, that is the system. You have it when you go by ski and there comes snow over you, that you will be found where you have lying under the ski. This is the same system. Snow founder, for example. And we lay this in the axilla after core needle biopsy. But we find the localizer, but sometimes we find the lymph node no more. I think very interesting. We have to look.
Yeah, that was reflected in the session before. Sorry, Mario. That is not too easy to place a localizer or whatever you do. Really in the lymph node. In the majority of cases, it is at the margin of the lymph node, or really in the near of the lymph node. So I have to say that is one point I'm really don't understand. We know that there is really a need for axillary biopsies. So that means there's really a need for absolutely well-trained radiographs with ultrasound, and people are brave enough to go for axillary biopsy. And trust me, whenever I begin to teach younger doctors, there was a lot of anxiety regarding anticipated problems in the axilla, vessels, nerves. Okay, that is an anatomically complex organ, much more than the breast, but it is difficult to go for not so trained people, to motivate them to go for really routine axillary biopsies. So, and then this pulse system is much more safe in a way for, I would say, for the beginner, in the first levels of experience. So that is one of the ideas too, to motivate and to move forward with axillary biopsies, because in the next couple of years it is absolutely necessary to focus on the axilla.
It all starts with the breast surgeons being trained in the ultrasound, as I always say, in Greece, where it is not a routine. And I want to say, I think there are also other systems where the needle doesn't just jump out, other handheld systems. But the plus of this system is that you can draw back the needle and just go into the lesion without the lesion's needle, so you feel more secure, I assume. I don't know if Dr. Marx wants to place a comment.
Hello, everybody.
Mario, do you want to make a comment about...
Mario, du sollst nur kommentieren.
Oh.
Mario, you have to speak. You are the clip finder. Therefore, we want to hear something. Clip finder.
I work together with...
Not an email to Karin Breitenbrum.
No. Also,
she invited you. She invited you to a drink.
I'm so impressed. I'm a little bit very excited. I work together with Prof. Markus Hahn. Okay, and we don't found every clips, and give me better ultrasound systems, and all is fine.
So then I will give over. Thank you very much for your comments, and I will give over to the co-president John, Mr. Yanni.
Yes, actually, we'll invite now Dr. Mastorakis to talk to us about innovative techniques in and materials in breast reconstruction. Dr. Dimitris, the podium is over to you.
Okay.
Thank you, Yanni. Thanks, Corina, Dr. Kodouli. Thanks for the kind words. I'm afraid I'm only a plastic surgeon at Newterres Hospital, not yet a director, but I appreciate the comment. So this, I'm afraid, is going to be a it's going to be a rather short presentation, since we're going to be talking about mostly new things that I was asked by Dr. Anastasakou to mention. So we're going to be mentioning a few things about Wayne Morrison, and I'm going to be presenting on two companies that I found are currently involved in creating scaffolds that can be used for breast reconstruction. And we do have, though, one clinical paper that presents the same idea by Dr. Rubin's group in Pittsburgh, and we'll mention our tiny experience. Few things about newer materials as far as ADMs and meshes. Again, I reiterate that these are my personal opinions as far as what I think is quite innovative in our days, and I'm sure this is not all inclusive. And finally, I was asked to put in 2 words about the neurotization of the breast as well as breast implant illness. So we're starting with, of course, the pioneer. No talk about this can be presented without Dr. Morrison, who's an Australian plastic surgeon, and at the days when plastic surgery was very much involved with prefabrication, was instrumental in developing his chambers, which he was implanting in the subcutaneous tissue, and he would show that in a space of several weeks or months, this was filled with granulation tissue and quite vascularized. At times, as you can see here, they would add an AV loop in the same chamber, as you can see here. And of course, when there was an AV loop, things would get much vascularized and much faster. But of course, even without the AV loop, there was still a production of tissue growing underneath these chambers. Of course, at the time, you see this is back in 07, these were non-absorbable. This brought his, from what I understand, the company that he was involved with, to design a biocompatible scaffold called Neopec, where, as you see here, coming out of times, would supposedly replace implants by implanting these scaffolds and allowing the space to be created and then to be popularized, rather populated by the patient's own fat cells. So let's see how this works. I know Dr. Mvani is very fond of CAD-CAM. You can see that we can basically use any biocompatible material or thread, such as the different suture materials or other biocompatible resorbable threads to create the shape that we want. So in the interest of time, we see that basically a scaffold comes together with the tissue and eventually is infiltrated by vasculature. And while it degrades, because we're talking about resorbable scaffolds, it would be infiltrated by cells, and eventually, while it disappears, it would cause regeneration of tissues. Several aspects of the scaffold would make it more or less prone to such an application, such as pores found in it, or the space between the threads of the scaffold, and how hospitable it would be for cells of the body to be infiltrating it. And this is what we see out of the Bellaseno company in Germany. basically they are already manufacturing spacers that can be implanted and later on be infiltrated with fat so as to create the space necessary to reconstruct the breast. And this supposedly could hasten the procedure. So you can see that they already have several key points. They claim that this is going to be, of course, natural tissue, and the scaffold will be aiming the growth of natural tissue with the patient's fat, and this is causing regeneration, of course, without the necessity to use cultivated cells or animal-derived products. There's no foreign material that's permanently implanted, and the risk of repeated surgeries would be reduced. And you can see that most of their literature comes out of the industry and the biofabrication journals. The other company that I found is a French company, basically stating same things, and they are interested in designing 3D spacers adapted to the morphology of the patients with the use of CT, but I suspect that in the near future this will be coming out as different sizes, just like implant companies do, and basically cause guided tissue reconstruction. So here it goes.
I'm afraid we can't hear the video.
Please let me add, of course, that they have no financial interest in any of the companies mentioned. So you see how this is looking, and I suspect this is going to be coming out in different sizes. Is this science fiction? Well, apparently no. This is a work of Dr. Rubin in Pittsburgh, and you see what he created with his team. They called this the Lotus scaffold. They used the tiger mesh, the seri, and the phasix mesh, which is basically a P4HB material, but it's a little harder, a little stiffer. So you see they had actually 28 patients, and they decreased the number of fat graftings to 1 or 2 postoperatively. Unfortunately for me, they used 2.5 sheets per breast. So this was their intraoperative picture and how they would proceed with fat graftings. And you can see the number of fat graftings they required: 28, 1, 53%, 2, and only 7% or 3%, the 3 or 4 fat graftings. Of course, the extracorporeal expansion is a very helpful adjunct to such a technique. And let me just show you our little experience. And this lady, unfortunately, as I told you, we were only able to use 1 sheet per breast because of reasons of cost, since 5 sheets per breast would be prohibitive at least in the Greek setting. And you can see the progress in 2 and now 3 fat grafts. This is the result on the operating table. I'm sure the plastic surgeons are very well familiar with this, but let me just show you how tiny the little marbles of fat are that are being implanted. So you know that there's no way that this will not be vascularized as a free graft. So you see another case, a similar situation, and you can see that we got from here to here with just 2 fat graftings. And is it vascularized? Well, yes. You see that this is a basically a nipple reconstruction surgery in a lady that has been reconstructed with fat, and you can see the bleeding in the fatty tissue underneath the nipple being reconstructed. On changing gears, something new is the way that Dr. Barnea's team out of Israel is handling capsular contracture, especially in the setting of radiation. They have been using fat, and you can see how with adding fat, they have significant improvement of fat reconstruction, and having only the smoking as a negative prognostic factor as far as how the post-radiation capsular contracture is going to be improved. And you can see that they eventually get to a small number to autologous reconstruction, much smaller than the previous ones. Again, a new topic is the neurotization. You can see how Dr. Spiegel's group is neurotizing the epic flaps by harvesting a sensory nerve just as it comes out of the rectus fascia, and bridging the gap to the 3rd anterior intercostal branch of a sensory nerve just by the internal mammary vessels. In this procedure, of course, the neurotubules are instrumental because they can allow the surgeon to bridge the gap satisfactorily. But as you can see, this can happen in different ways. Nerves can be threaded through flaps, and in this case, usually nerve grafts, allografts are being used, and this is the way one can neurotize the area of the nipple through a flap. And for this, you either find a little nerve branch underneath the nipple, or even anastomose it to the nipple itself. And you can see the same thing over here. One is dissecting the sensory branch. Now, this is a little tricky as far as oncology is concerned, because I'm not sure how safe it would be to dissect so much length of a nerve inside the breast. But if you do that, then you can always anastomose it to the backside of the nipple. And you can see here in the setting of an implant reconstruction that using a xenogram, rather an allograft nerve, one can bridge the gap and provide the sensibility to the nipple, as you can see in this paper. I think the Motiva implants are a change from what we're used to be doing. They're mentioned as the 6th generation implants, and they have several salient points, one of which is being, of course, the nanosurface, which, to my knowledge, so far has not shown a single case of ALCL in the 10 or 11 years that they're at. And of course, they're now coming out with the new expander, which is a smooth, basically nanotexture, for all practical purposes smooth, but even more importantly, it does not have the well-known magnet. So this is compatible with magnetic resonance. They're using some sort of radio frequency identification of the port. The newer generation of Braxton, I think, is very interesting. It is shaped and allows for quick integration, and is much faster in incorporating an implant and proceeding with the reconstruction. Same thing it goes for the Galatea meshes. As you're probably familiar, Galatea has been purchased by B&D, and things are being changed as we speak, but they come out with shaped meshes as well as thinner meshes. So these are also interesting things to keep in mind. Finally, a slide about breast implant illness. Well, as I'm sure this group is well familiar with that, their symptoms are frequently non-specific. They vary in severity and can affect nearly all organ systems. As you know, this has been described in the literature for several decades now, and the results have always been mixed. Inflammation and capsular contracture may be the common denominator under these things, but in this day and age, we find that social media and influencers have been creating a huge noise about that, leading a lot of people to surgery, which actually is not supposed to be very benign. Women are being asking for total capsulectomy, and actually total capsulectomy without even opening the capsule, which of course can lead to significant morbidity without having any serious data to support that the symptoms are going to be improving. So long, comprehensive follow-up studies are needed, and earlier studies in the 90s, where the whole thing about silicone had emerged, have shown that in short term you might find benefits, but in the long term these benefits don't seem to last. Of course, there are several other interesting things like prophylactic lymphovascular anastomosis, or the use of the omentum together with ADM and fat grafting to reconstruct the breast, but I'm sure that there's many more things. One last thing is that this process might explain how the inflammation happening in and around the breast implant and the presence of silicone particulates could be the common denominator underneath capsular contracture, allergies, BII, or also BIA-ALCL. Thank you for the opportunity, and I'm happy to address any questions as I can.
Thank you very much, Dimitris, Dr. Mastarakos. I would prefer, because we're a bit back in time, that we proceed to the next presentation and take all the questions about both presentations and comments, because they're both surgical together. Thank you. Then perhaps Dr. Mario Marx would like to.
Yeah, hello.
Mario, welcome as a general and plastic surgeon and breast surgeon with a special expertise in intraoperative ultrasound. You could show us your experience.
Okay.
Yes.
Wait a little moment. Okay. Can you see it? No. Cornelia, can you see it? Hello?
Yes, we can see it. We can see it.
You can see it?
Mario, start now. We see
sorry,
everything.
Sorry, but
yes,
yes.
Come on, man, show it.
No, wait a little moment. My presentation.
Come on.
Wait a little bit. I'm a little bit
Okay.
older than you. Okay. Also, dear colleagues, Dr. Gianni Anna, Dr. John Janas, and Cornelia, I would like to thank you most sincerely for your honor of speaking at your annual meeting of the Greek Society of Breast Surgery, and especially Cornelia Anastasakis. I had to have the opportunity to meet and appreciate Cornelia at several surgical courses in breast surgery in Germany. Okay. I haven't no conflicts of interest with the industry. It is always helpful if need help to accept it and to have a look over the garden fence to broaden your horizons. In this case, the left side, as in the beloved arm for my grandmother. The indications for intraoperative ultrasound in the hand of a surgeon. We use intraoperative ultrasound for the following indications in order to achieve an optimal surgical result with few complications. Time means not only saving money, but also reducing complications for our patients. The ultrasound device is standard in our operating room. Yes. The use of ultrasound in surgery makes as a seeing surgeon. The examples show a variety of possible applications to achieve optimal results. For example, resection benign interductal papillomas, planning breast conserving therapy, precision removal of a sentinel lymph node under magnifying glasses with a gamma probe, autologous fat grafting under ultrasound view with stepless injection technique, or optimization of a fat graft. But here you see the condition after 1 year, ultrasound guided mastectomy with prepectoral implant reconstruction in the morning sun. Whereas not much gland left. A little crediting to Stefan Pepke from Munich. The discussion as to whether we should completely remove the tumor and its precursors after neoadjuvant systemic therapy in old or new limits is passionate in Germany. In my opinion, both the adjuvant therapy and after neoadjuvant therapy, a complete surgical resection of the primary colonization area, the carcinoma, and the DCIS necessary R0. After a successful systemic therapy, a complete pathological remission, it is possible to operate in reduced volumes. It is my opinion. With intraoperative ultrasound, it is possible to safely visualize both in the carcinoma and the surrounding tissue and to see the relationship to the skin as well as to the thoracic wall and the surrounding cysts and macrocalcifications as well as marking clips in the discussion that we are using during the punch biopsy. A hematoma caused by the punch can also be clearly seen. Here you can see a tumor bearing a segment resection operated with ultrasound from 2004. Close cooperation with the radiologist and pathologist is a basic condition for successful surgical therapy. The surgeon must know the work of the radiologist and the pathologist exactly. The Academy of German Society for Sinology offers all sinologists to possibility of interdisciplinary father training. In 2009, in a retrospective study, we were able to demonstrate a significant advantage of ultrasound-guided tumor resection for non-palpable unifocal breast carcinomas and 360 and compared with the wire marking 343. Crackle et al. Shows the intraoperative ultrasound guidance for palpable breast cancer, and they show us that only 3% of tumor infiltration could be detected in the resection margin under ultrasound vision, under 17% without ultrasound. Our randomized single-center prospective study, MAG-001, was able to demonstrate a significant advantage of ultrasound-guided tumor resection for non-palpable tumors compared with wire-labeled non-palpable tumor resections. It is none other example for ultrasound. Here is an example of a 15 years young female patient with polylobular fibroadenoma that was removed under ultrasound guidance. In my experience, an intraglandular reconstruction is not essential, and the existing glandular parenchyma unfolds again after about 12 cycles, 1 year. Surgical access for benign tumors should be via the inframammary fold if possible. For 18 years, I have been using autolog tissue as deep flap or FCI flap or IGAP with 99.5% microsurgical connection to the axillary vessels under the microscope. After 12 months of healing of the graft, finalization usually takes from the symmetry formation, creation and neomamilla, ultrasound guide suction of partial indurations or ultrasound guide lipotransfer for volume optimization in combination with the adjustment of reduction plastic. The device, the design factor for the indication of a deep flap or FCI flap is the morbidity and the wish of the informed patient. I do not use TMG because of its lifting morbidity in the genital area. For 18 years, I have enjoyed the privilege of being a cooperation partner of the University Breast Center in Tübingen and of living science and quality of care in the treatment of breast cancer patients together with my colleagues and friends in Tübingen. Almost daily, Prof. Markus Hahn and I exchange our questions and views on the optimal treatment of patients. Thanks to the intraoperative color Doppler ultrasound application, we do not need contrast-enhanced computer tomography. The perforators or the vessels are already localized during the preoperative planning of the deep flap or FCI and documented in a preoperative protocol. The connecting vessels in the axilla are visualized and recorded preoperatively. It is not for us. Ultrasound and loop guide glandectomy with intrapapillary removal of the milk ducts is standard in our clinic. However, prepectoral implant reconstruction or autologous tissue reconstruction is performed. In BRCA-positive patients with the wish for prophylactic glandectomy, by means of deep reconstruction also possible on both sides or unilateral FCI. In the case of very small volumes, in my opinion, only a glandectomy can be performed. 1 year postoperatively. Here you see a 42-year-old, young lady, BRCA positive patient after bilateral glandectomy and immediate reconstruction with deep on both sides. Our patient complains about the oblique scare on the lower abdomen. We will straighten the scare and remove the monitor island after the lower breast fold. The monitor island in this area. Thanks to intraoperative ultrasound, we can see the scars in the axilla, as well as the vessels and lymph nodes with them. It's possible to see. And intraoperative ultrasound is everyday standard. The example of the thoracodorsales vein shows the wide range of vessels diameters in the axilla for anastomosis. No? Small, not so small, and big one. All is possible. The axilla is perfect for me. And with the intraoperative visualization of the perforators in the deep flap or FCI, it is possible to visualize the different vessels of us very well and whose significantly reduce the operation time. The average incision suture time is approximately 2.5 hours for a single and approximately 4 hours for an FCI. The FCI flap is equivalent and the same as the deep flap. The scar resection on the axilla after sentinel or axilla dissection is usually performed in the supine position and under ultrasound vision. As the scars can cause significant dislocation of the axillary vessels. Under the microscope, the anastomoses are connected to either the thoracodorsal artery or vein, or the circumflexor scapulae artery and vein with 10/0 etilone. In the prone position, the FCI flap is lifted under magnifying glasses and ultrasound, and in the supine position, it is reconnected axillary under the microscope. And in an FCE flap, one brittle of the buttock lower half and about 2/3.5 one are lifted under ultrasound vision to visualize the most competent vessels. We'll see a preoperative plan and our special occlusion dressing. This patient was referred for autologous lipotransfer. This makes no sense. The indication is for capsule and implant resection with reinsection of the pectoralis major muscle and reconstruction with FCE flap. The primary operation to remove the glandular body was excellent. Here it is possible to see the muscle part, the mesh, and the implant. Our patients are mobilized on the first post-operative day and are discharged home after 7 days. After 12 months, symmetry can be restored if desired. And here you see operation situation, free flaps, and this is a scar later. This is only a scar area, bilateral FCI flap, tubing 12 months post-operatively, with reduction of sensibility in the upper dorsal thigh area. Only one slide for another indication. The autologous lipotransfer is carried out ultrasonically, stepless with the citory. We also use intraoperative ultrasound for autologous fat transfer, both for liposuction with water jet technique and for infiltration. The infiltration fat is injected under ultrasound vision with a stepless injection to achieve a good result. Only this. And the last but not least, this is a very interesting for us. The search for a surgical therapy of arm lymphedema of breast carcinoma treatments occupies us. 11,500 arm lymphedema cases requiring treatment we are treated in Germany, following guidelines-based treatment of breast cancer. Okay. We assume that the scar-related displacement of the axillary vessels towards the caudal region can lead to lymph drainage problems after axillary surgery, whereas a vector compression in the axilla with caudalization of the vessels to caudal, artery, vein, and also lymph vessels, cause of the lymphedema. Our concept of surgical ultrasound-assisted lymphedema therapy. The lymphedema developed 1 year after breast-conserving therapy, which accompanied by wound healing problems. How can we help the patient after more than 6 months after classical physiotherapy? We published our concept for the treatment of arm lymphedema after breast cancer treatment 2 years ago as an alternative to lymph node transplantation. And you see the possibilities of reaugmentation of the axilla after scar resection, FCI, DIP flap. Here we look in the operating theater in tubing, and here is the turnover flap. It's also possible to reaugmentation the axilla. You can see what caudalization of the axillary vessels can be caused by a scar. This one. Yeah, okay, it's possible to see the vessels and behind the lymph vessels. You can see how the ultrasound guide turnover flap, lateral thoracic artery and vein is brought into the freely prepared armpit and fixed there in the axilla. This patient did not want breast reconstruction, but only he hoped for improvement in her lymphedema problem. The reaugmentation of the axilla is intended to prevent or reduce a renewed displacement of the axillary vessels caudally in order to improve lymph drainage. The patient already moved their arm actively from the first post-operative day. And here you can see after the skull removal in the axilla, the relocation of the vascular tissue from the lateral thoracic wall to the cranial in order to stop a caudalization of the arterial, venous, and lymphatic vessels. The turnover flap is fixed cranially. And this one is a turnover flap. And you bring it in. Okay. With the infrared camera, the perfusion of the pedicle turnover flap and the lateral thoracic artery and vein can be detected using indocyanine, which is used for reaugmentation of the axilla after scar resection. Prospective studies must show us which patient with lymphedema benefits from which surgical concept after anatomical consistent scar removal in the axilla. Is the reaugmentation with autologous tissue sufficient? Is lymph node transplantation the method of choice? Which patients do not benefit from surgery? Let's find out together. It's only an example after a successful operation. This one here is 59 young patients with a right breast carcinoma treatment 20 years ago with implant reconstruction and suffered from lymphedema for 19 years. Surgery was a capsule resection with implant removal and retraction of the large pectoral muscle, complete removal of the axillary scars, and cranialization of the axillary vessels. Another patient for me after 13 years with lymphedema, and the patient on the left can play the tenor flute again after turnover flap for 5 years. Intraoperative ultrasound make us seeing surgeons and can be learned by any passionate surgeons. The use of intraoperative ultrasound shortened operation times, improves surgical precision, and is cost reduction factor. Thank you for your attention and come very much to our annual surgical courses in Radebeul and Tübingen. Goodbye. Thank you.
Thank you. You hear me? Thank you very much, Dr. Marx. Thank you, Mario. It is very, very impressive what you showed us, and I'm sure it will be even more impressive if we have the opportunity to be again in your OR, in your surgery. So we would like to start a surgical discussion. Perhaps Yanis, you would like to.
Okay, thank you very much. Thank you very much, both of you, for the excellent presentation in relation to breast reconstruction and innovative technique. I would like to invite Andreas to give us a comment in relation to the, I mean, I know that you do a lot of free flaps and you are an advocate of free flaps, but I would like to find your uptake in relation to the new devices that come up in the market for prepectoral breast reconstruction.
Actually, thank you for the question. There is no doubt that the autologous reconstruction provides by far more naturally looking and more long-lasting results. But unfortunately, the majority of our reconstructions have to be implant-based reconstructions. There is no doubt that worldwide, over 80% of breast reconstruction are performed by implants for several reasons. So we have actually to look and to identify the perfect replacement for the autologous reconstruction. And there is a lot of discussion nowadays about the prepectoral breast reconstruction, but I think in my experience that I have used a lot of prepectoral reconstructions, and I have used Braxton, MES, and I have favorable experience, to be honest, with Braxton, but I would be very skeptic in the future about prepectoral. I think we have to justify the case that is suitable for prepectoral breast reconstruction, because even with subpectoral reconstructions in the suitable patients, we can get very good results also with the use of mesh in subpectoral breast reconstruction. I was, of course, very impressed by the scaffold, but I would be also very skeptic how they use this scaffold in a radical modified mastectomy, because of course you may create the conus of the breast with gradual lipotransfers, but I don't think that you're able to reconstruct the skin envelope, at least at the radical mastectomy. Maybe it's a very good solution, and maybe it is the future for the immediate reconstructions, the scaffolds.
Thank you, Andreas. So in relation, I would like to ask Dr. Martz, in relation to neurotization procedures, do you do any of these? Do you think there's a scope of trying to re-innervate a breast reconstructive tissue?
No, we innervate not the free flaps. And a normal standard in my clinic is we glandectomy, and we have the normal skin and transplant only fat to composition the gland.
If I can make a comment, I used to do the neurotization of the free flap, but to be honest, I don't see any point so far.
Ich höre ganz schlecht.
You can hear me?
Cornelia, kannst du mir helfen? Ich höre ganz schlecht.
Ich glaube, das hat vielleicht mit dem virtuellen Background zu tun. Das kann damit.
Habe ich was falsch? Soll ich was ausschalten?
Naja, ich weiß nicht, aber hörst du jetzt?
Ja, besser, stimmt. Okay,
Ja.
sorry. Kannst du mir helfen?
Ja, natürlich. Andreas, can you repeat, please?
No, I was saying that I used regularly to neurotize the free flap by the intercostal nerve, but most of the patients, even if you don't neurotize your free flap, they get a protective sensation. Actually, it's very remarkable when you do some lipotransfers to a DF flap, the patients, they do have sensation and they do feel it. Of course, you add some more time when you do neurotization of a free flap. Now, regarding the neurotization of the nipple, should be a lot of oncologic thoughts about that, if it's very safe to do it.
Okay.
If I may interject, the point of the neurotization here has to do with the central area of the breast, that in no mastectomy have I ever seen or heard of a breast being sensate. So it's the area of the nipple that is in concern. And actually, in the States, there's significant discussion about transgender individuals that have mastectomies and are interested to have their nipple areas neurotized. And of course, the crucial in these attempts are the use of the neurotubules or the allograft nerves that are being used so as to have no tension repair. As far as the scaffolds, these are obviously addressing only skin sparing and ideally nipple sparing mastectomies. My concern with those would be how you can make sure that the tension of the scaffold against the skin would not cause ischemia issues. But I think this is a case-by-case assessment, and ICG angiography is crucial as far as I'm concerned. Thank you.
Dr. Nestle-Kremling, möchten Sie vielleicht, would you like to make a comment?
I would like to make a comment on the, yes, very, very, yes, impressive presentation of Dr. Mastorakos and the subject of implants or materials, better to say. So do you use it routinely, or how many cases did you do with, for example, Bella Zeno or Neopec or something like that? Because I would be interested in the difference to lipofilling as we know the concept by, for example, Professor Überreiter. Like you do lipofilling after putting an expander or an implant, and to do it step by step.
Thank you. That is a great question, Dr. Nestle-Kimmerling. as they say, if you do a case, you say in my experience. If you do 2 cases, you say in my series. If you do 3 cases, you say case after case after case. We're now in my series situation, so we've done 2 cases, and I think the main advantage is that you can address one of the most important things of breast reconstruction, which is assuring significant projection of the breast, as opposed to just lipofilling, which of course can address the volume, but not so much the projection. Of course, as you can realize, we can only use materials that have already been approved for use in the breast. So we can limit our use of something like Galaflex or something, or Seri or whatever, but a material or tiger mesh. To us, only Galaflex is available. We do have the Phasix one, but number one, is not approved for use in the breast in the European Union, as far as I understand. And number two, it tends to be a little more expensive. But I would probably prefer it because it's a little stiffer than Galaflex. Thank you.
And the resorption, what about the resorption time of these materials? Is it months, weeks, or?
This is in the area of, it is P4HB, polyhydroxybutyrate. So it takes about year and a half, close to 18 months, I would say.
Yes, because we know from the tiger mesh, it is going up to several years, or from the Seri scaffold we used within the study, and especially Seri, as you mentioned in one of these devices, there is a silk surface, and silk does have basically an allergic potential. We realized in the Seri scaffold study by the red breast syndrome in about 10% of the patients. So we stopped completely to use this silk containing material.
I would like to say about the Belaceno that it is a very promising study, of course, with the Senella implants from Leipzig, but they're not tested sufficiently in humans, so they're not ready to present actually results. And let's see, it would be fine if women had to deal with less toxicity in terms of implants. Dr. Stefan Pepke, sorry, you raised your hand. I would like to ask you your opinion about this.
Yeah, only a comment to Andreas. What we have seen in clinical practice since exactly 4 years, since October 2017. So starting in Italy, crossing Europe, especially in Germany, we switched completely our strategy from subpectoral implant placement to prepectoral implant placement. And there is no doubt, because we have prospective mitrocentric data, that this approach is very beneficial. Recovering in the majority of our cases the implant with the titanous polypropylene mesh. Caroline has really good experience with the partial resorbable mesh. She presented her data in the German Society of Sonology in the SEER meeting. So there are some materials that is approved and tested in prospective trials and parallel trials and case studies. And there is no doubt it's a question of indication. I have a plastic surgeon in my team, so that we have no frictions regarding indication, regarding the best way for the patient. And if the habit of the patient is perfect for autologous flap surgery, we do that. But in cases with immediate delay reconstruction, cases with radiotherapy, so we go for placeholders with the mentioned Motiva, with the Flora expander from Motiva. So there are some different ways, but nevertheless, the majority of cases will be reconstructed by implant-based surgery, and we are absolutely roughly fair that we are saying, okay, implant surgery is one-step surgery, but it's for the whole lifespan of the patient, at least one revisionist surgery is necessary. So, but the material is proof, the material is very fine regarding side effects. What we have in our prospective trial with the bra pocket, we have a complication rate below 8%. So that is regarding flap necrosis, seroma, wound infection, all the things. That is a well-established idea. And also in cases, if you have seen how Mario is performing the glandectomy in a very radical way, what is necessary for the patients with BRCA1, BRCA2 mutations, and also with large DCAS, it is a well-established method. So I know that we have complications with mesh-based surgery, but we have to focus too on I would say the major subset of patients with a medium BMI around 24, with a medium implant volume around 400. In these kind of cases, it is perfect to do it with implant surgery.
Dr. Marx, yes?
Yes, Cornelia. Only short. Regarding the sensitivity after glandectomy, we leave the perforators and sensitive nerves intact in the inframammary fold, which should be displayed intraoperatively, so that over a year is very often an improvement in sensitivity. Only for the question.
Thank you. I would like to. I have two questions. One for Dr. Marx. So, if you have any morbidity from the nerve with this gluteal flap, I mean, when the women are sitting, do they experience any pain? And then I would like to ask Dr. Mastarakos if there are any studies comparing implant holders, carriers with non-implant carriers concerning silicon in blood or heavy metals or things like that. So perhaps we start with the question for Mario. Ob Sie Probleme beim Sitzen haben?
No.
Nach dem Gluteus.
I started with the FCI for 10 years and a little bit more, and now we haven't problems with sitting on the chair now. The sensibility reduced, yes, okay, but we transplant only fat, and this is a calculation for a new aesthetic breast. And no, I don't see many problems with sitting on a chair.
Thank you.
Dr. Marx, can I ask you, what sort of volume do you get from these FCI flaps you do?
Oh, it is, yes, from 150 cubic to 850 cubic.
Okay, thank you.
The vessels are very competent.
May I make a question, Dr. Mario?
Yeah.
Because FCI, it's a very straightforward flap. It's very
Why?
Because you have a constant vessel, you can find it easily.
No.
It's a settled vessel, no?
No, 8 to 12 centimeter.
No, I mean, it's a very straightforward flap to do because it has relatively constant anatomy. It's not, for example, like the F flap or S-gap flap. It has no technical difficulties. So why not? It's not popular. This is not popular at all. Why? Because I know the flap. It's very straightforward.
Lovely to operate.
Yeah.
And for me, it's stress to speak in another language. I learned 14 years Russian in Germany. I was born in the eastern part. I stay in Brazil, etc. But languages is not so good for me. Come to me and we operate together, or I come to you and we operate together. Yeah, it is very easily to operate under ultrasound. So you see the vessels, so you see variants of anatomical vessels. Left is another, as the right side is fantastic in all women. But I see a problem. It is possible to see under ultrasound, and it is, sorry, it is learning, and it is not so difficult.
Okay, maybe he didn't understand my question, but
Stefan, let me together operate with in Athene.
we have to organize a course with the German Society. I
go by bike if it is necessary.
After COVID, after the...
With Caroline also.
Yes. Mario, du hast mich vergessen. You forget me. Yes, I will come too. Yes.
Ich habe die...
Of course.
I lovely, my past president.
So I would like to address this question to Dimitri, because I think, in my opinion, I'm not a plastic surgeon, of course, but I think the absorbable implants perhaps could be the future if they are not toxic. I am not sure that many women who think they do not experience any symptoms from breast implants, that they really do not experience. You have to compare populations, because if the symptoms are very subtle, you know, cognitive and things like that, they think it is a menopause, but it could be from the silicone. So I would like to ask Dimitri, perhaps, if we have any studies about this.
Well, yes, this is, of course, a crucial question, and it had been addressed extensively in the 90s. There are many studies that report that actually removing the implants does have a positive effect. The problem is that they're usually retrospective, without controls. You have to keep in mind that all the symptoms associated with BII are very much placebo influenced. So the 20 or 25% of change could easily be explained about that. There's no evidence that people without implants do not have silicone in their bodies. I have to remind you that silicone is the lubricant in IV tubings, in toothpaste tubes, and we're exposed to silicone every day. So I haven't come across a randomized trial that showed that removing implants did improve symptoms in the long term. Keep in mind that several of these women are also having issues like rheumatoid disease or fibromyalgia. And early on, after the removal of the implants, they feel better. But then in a short period of time, if you keep following them for more than 2 years, it seems that the symptoms recur. And lastly, we have to take away the women that have capsular contracture, because even a small amount of capsular contracture could be associated with tightness of the breast and feeling of difficulty breathing and stuff like that. So if you take out the women that have capsular contracture, it's really very difficult to prove that there's actually a change. The American colleagues now find themselves in a very difficult situation because they have several women, actually quite a few hundreds or thousands, that are requesting what they call total capsulectomy. And as I described, this is a quite morbid procedure because they actually request for the whole of the capsule to be removed intact and in toto. And this, of course, has a significant chance of pneumothorax, bleeding, and all these things. Basically with no evidence. And some of them are actually doing it and are building practices on that, again, with no evidence.
Thank you. Thank you very much, Dimitri. Is there any other comment?
Thank you.
So if there isn't any other comment, I would like to thank you all very, very much for joining us, for being here. It was a great honor and a great pleasure. And I hope that we can organize some next time without the COVID, something where we can work together, operate together, and see Athens and the islands together. So
thank you very much.
Vielen Dank. Vielen Dank.
Thank you very much. Yes.
Vielen Dank auch.
Thank you.
Vielen Dank.
Nice
Tschüss.
Bye.
Thank you, Yanis. Thank you very much. And I would like then to give over, I think, Michalis, if we can have perhaps a small pause for about 10 minutes, and then we can continue with the next round table with
Yes.
Eleni
Let's do that.
Payaku
We
I think
skipped
it's
our
done.
first break, so we should have a small break at this point.
Okay. Thank you.
Excellent.
Bye-bye.
So be back in 10 minutes.
Okay.
To create the next level in elegant innovation, our engineers work to develop a streamlined approach to breast biopsy technology. The result? The BD Elevation Breast Biopsy System. BD Elevation enables physicians to obtain diagnostic quality tissue by leveraging the advantages of vacuum-assisted technology and the freedom of a core needle. The absence of tubing allows mobility during the breast biopsy procedure. Multiple samples can be taken with a single needle insertion. Optional firing gives you flexibility during the biopsy. And BD Elevation Smart Mode will notify you when sampling even the densest breast tissue. Available in 3 probe sizes, with echogenic markings along the cutting cannula for improved visibility under ultrasound, BD Elevation streamlines breast biopsy procedures. Plus, its intuitive ergonomic design allows one-handed operation and sampling in all clock positions. It's quite simply the next level of elegant innovation in ultrasound-guided breast biopsy procedures. To learn more about the BD Elevation Breast Biopsy System, contact us today.